To everyone logged in already, I'm just waiting another few minutes for the rest of people to trickle in to the webinar. Hi, good afternoon, everyone who's logged in. Thank you for joining us for the Together in Care webinar series. My name is Melissa Duran, and I'm going to be moderating today's session. Today's speakers will be Dr. Sinead Brady and Brynn McNamee-Tweed. Both are members of Columbia's Neonatal Comfort Care program, and they will be presenting today on providing thoughtful redirection of care. Firstly, we just want to remind all of those joining that CME credit is available for live and recorded sessions, and MOC Part 2 is offered as well, so you can access those through the QR code on this slide. Next slide, please. And next month, our September webinar will feature Dr. Cortezo, our first speaker in this series. And she's going to be giving a talk dedicated to end-of-life symptom management and complex chronic NICU symptom management. So we're happy to have her back on Monday, September 8th at 2 p.m. And you can register with the QR code listed here in the center of the screen. The QR code on the left is a link to the Together in Care webinar page to view past recordings and to register for other upcoming webinars. And now I have the pleasure of introducing our speakers for today. So Dr. Sinead Brady is currently an assistant professor of pediatrics at Columbia University Medical Center. And during her training as a fellow there, she worked closely with Dr. Paravicini, where she learned the importance of being able to support families, especially when medical interventions were not enough to ensure recovery. Dr. Brady went on to join the Neonatal Comfort Care program at Columbia, where she is currently the Associate Medical Director. She pursued additional training in palliative care through the Harvard Medical School's Palliative Care Education and Practice course. and it is Dr. Brady's belief that the best care for our patients is not one just focused on medical interventions, but one that makes space to learn about patients' families, enabling our team to deliver care that supports the entire family throughout the perinatal journey from diagnosis to delivery and beyond. Our other speaker today is Brynn McNamee-Tweed, a perinatal palliative care midwife in Columbia's Neonatal Comfort Care Program. She started her career as a registered nurse in New York Presbyterian Morgan Stanley Children's Hospital, NICU, before moving to the University of Michigan, where she graduated with a Master of Science in Nursing in Midwifery. Following some time working as a certified nurse midwife in OBGYN private practice, Brynn returned to Columbia and now works as a perinatal palliative care midwife, meeting some families prenatally at the time of fetal life-limiting diagnosis and others in the NICU with their critically ill infants. Brynn's unique experience with both maternal and neonatal health helps her better meet the needs of families throughout the perinatal journey, particularly for those babies facing life-limiting conditions. So it is with great pleasure that I will pass this over and we can begin our webinar. Thank you so much.
Great. Thank you so much, Melissa, for that introduction. And thank you everyone for attending this webinar. We're excited to be here and talk a little bit about what we do here at Columbia. So before we get into the lecture, we thought we'd spend just a couple of minutes talking about our program to give you the context in which we work in the NICU at Columbia University Medical Center. So our team, the Neonatal Comfort Care team here at Columbia, is made up of two neonatologists, myself and Dr. Paravancini, who's the founder of the program. Then there's Brynn, who, as you heard, is a clinical nurse midwife and former NICU nurse. We also have Sarah, who is our clinical nurse coordinator, who also is a former NICU nurse. And then we also have mental health support for our families from a clinical psychologist, as well as a support group that's run by a former NICU nurse who has a master's in psychology. So we meet families prenatally who have been given a fetal diagnosis of a life-limiting condition. We often meet our families multiple times prior to the birth so that we can help families navigate what kind of care they'd want their child to receive on the spectrum from comfort care to full intervention. Really, regardless of what the family chooses, our team continues to follow them. If they desire comfort care at birth, then we'll act as the primary team. And if they choose full intervention, we stay on as a consultative service to support both the family and the team, and then assist should the family wish to redirect care. As you can imagine, Columbia is a very large referral center. We have an infant cardiac unit that gets referrals from all across the tri-state area and beyond. And for that reason, we tend to have a pretty interesting caseload of patients that we see. To give you an idea of how many cases we see in a year, last year we met with 79 families and had a total of 371 encounters across all of these families. We also had 17 NICU consults. So these are NICU palliative care consults of families we did not meet prenatally. Of the families that we did meet prenatally, the majority did opt for comfort care, but 13 decided on intensive care. And of that 13, 9 families opted to redirect care after a trial of intensive care. So now that you have a little bit of context of the context in which our team works, we'd like to continue with the lecture. For this talk, we really wanted to focus on the actual redirection of care. The conversations and exploration of values with families leading to the decision of redirection is such a vital component and skill that takes a lot of practice. However, we really don't touch on that at all in this talk because that could be multiple lectures and interactive sessions in and of itself. We are instead focusing on what to do once the decision for redirection has been made. After today's talk, we hope you have a good framework for how to prepare for redirection of care, how to manage the actual redirection of care, and how to best practice postmortem and bereavement skills for our families and our teams.
So the decision to redirect care is an agonizing one that's challenging for both families and clinical teams. And we hope to share our center's experience in perinatal palliative care to offer suggestions for how to operationalize the redirection, both logistically and psychosocially. As we walk through the process of redirection, we want to start by calling attention to what parents have said influence their grief and ability to process their loss. These are overall themes, and it's important to remember that each parent is unique and an individual's culture, language, religion, or simply preferences impact both their choices and grief process. Factors that affect the future emotional burden of families, as described by parents, include their ability to spend time caring for their child, including performing routine parenting behaviors. Another important factor includes parents' perception of whether their child is suffering. We'll talk about general pain management strategies briefly, but an important aspect is not only the elimination of pain, but also parental perception of the infant's condition. Explaining away a family's concerns with the use of pain scores does not actually contribute to a good death. Instead, a combination of education, pharmacologic and non-pharmacologic methods of attending to an infant's pain, whether perceived or clinically demonstrated, can be helpful when concerns about a child's comfort are expressed. Communication experiences with clinical team members also impacts the long-term emotional burden that parents face. This includes how families are spoken to and the frequency of communication, but also perception by parents that they're being heard and respected. And then finally, parents reflect on the fact that their family had access to support beyond the narrow clinical team. This could include social work, psychologists, or chaplains. Hopefully, these can serve as guideposts for your team as you navigate the nuances of redirection, reminding us all that while we're making end-of-life decisions in a clinical context, families just see their child that they love and want to comfort and protect. Whether we're talking to families at the bedside or members of the healthcare team in the break room, it's important to be really intentional about the words that we use. It can sometimes seem trivial, but your word choice sends a signal about how you see each neonate. When we say things like, "This baby's condition is incompatible with life," it can send a message to families that we see their child as hopeless and not worth caring for. Others see a withdrawal of care as the medical team abandoning their child when they're at their most vulnerable. By changing how we talk about our patients, we communicate to families and clinical team members that we'll continue to care for their baby, and we believe that this infant is worthy of attention and support. Some phrases that you can use instead include redirection of care, life-limiting conditions, removal of life-sustaining therapies, and then we use concrete words like death and dying.
So really, like any procedure that we do in the NICU, the preparation is key. You don't ever want to get to the bedside of your patient without a plan that the entire team's on board with. As a team, you really should review what drains, lines, and respiratory support are in place so that you know what will need to be tended to. You also want to have an understanding of what medications you're going to have available to you. Ensuring all testing that the parents want is done prior to starting this redirection process is also really important. If the parents are interested in genetic testing, it's important to find that out before you're removing a line, such as an A line that could easily get you those labs. So you then don't have to consider pricking the child to get the blood for the genetic tests. But the most vital component in preparing your team for redirection is giving space and time for questions. In our center, we have a very large nursing pool with a lot of new nurses, as well as learners at different stages from interns to fellows, which I'm sure a lot of you practice in a very similar setting. For many, this might be their first time being involved in redirection of care, and walking them through what you expect to happen during the redirection will be helpful so they feel prepared. For example, how long do you expect the patient to live is important framing for the team, as they can best manage expectations for the family. The huddle also gives the team a safe place to ask questions regarding the redirection process or help them better understand the family's decision-making around deciding to redirect care. This team brief does not take long and lets everyone be on the same page and allow the team to present a united front to the family. This approach of having a team huddle prior to redirection has been studied and has been shown to have a positive impact on the providers participating in the redirection. The first study is out of Hopkins from 2006. Russian and colleagues looked at how the implementation of different support systems helped support the pediatric providers who were involved in redirection of care. They implemented a patient care conference with the aim to clarify end-of-life plans of a patient and allow opportunity for questions and feedback. They also developed bereavement debriefing sessions with a goal to help providers reflect on the case together. 61% of providers who participated in the study rated team morale higher after the case conferences, and 98% of those who participated in the bereavement sessions felt that they were useful, with many noting that they felt more connected to their colleagues and less isolated. The second study is a similar, albeit smaller study performed more recently in a NICU in the UK. It's a cross-section mixed method study in which the team explored providers' experience who attended pre-briefs and debrief groups prior to redirection. From the qualitative content analysis, themes that emerged were a fostering of connectedness with others and team unity, as well as a validation of feelings and values. I really think in practice, these groups, whether they're formalized as they are in these studies or informally led by the team prior to redirection, they're incredibly important to have. The primary team or palliative team that helped the family make the decision of redirection has the benefit of really understanding the family values and choices. By stopping and taking the time to explain that and answer questions to team members who didn't have the opportunity to be part of those complex conversations can really help with the understanding and improve moral distress associated with taking care of these patients.
So after the medical team has met and agreed on a potential plan of care, the family needs to be prepared for what this plan of care means and what it could look like. So preparing the family emotionally includes providing opportunities for parents to parent. These babies have had short lives and may have been connected to machines or lines that impeded their family's ability to hold or bond with their baby. And we want to offer those opportunities now. This can include bathing the infant, changing their diaper, or dressing them up. We also ask if there's specific religious rituals or figures they would like to incorporate, like a baptism or the presence of their family's rabbi. We also try to time the start of redirection to accommodate other family members or friends that want to be present. We ask if there's anything else that's important to them, like having music playing or taking the baby to the garden. But it's important to offer suggestions, as families often can't articulate or even imagine what they might want to do in these situations. Crucially, we include child life specialists for memory-making activities and legacy building. We encourage parents to participate in the memory making, as one study showed that when regrets were addressed, parents focused on actions that they didn't take during the brief time they had with their infant. They did not reveal regrets about the life support decision itself. So redirection can happen at the bedside if there's a way to ensure privacy, but a separate room that's less sterile is ideal. We also offer opportunities to do skin to skin and discuss, depending on how long we anticipate the infant will live, who will hold first and last. Timing can be a really difficult element of redirection, as families may feel confident about their decision to redefine the goals of care, but when the infant lives longer or shorter than anticipated, it often leaves families in a really challenging liminal space. It's not uncommon for parents who agree on the overall goals to have different perspectives on the pace of its reality. For example, a father who is overjoyed that they're getting more time with their baby than anticipated, while mom who is also very happy for the extra time, but feels guilty for just wanting it to be over. Neither reaction is wrong, so it's our team's responsibility to meet each parent where they are in the grief process, acknowledging that emotions are going to be nuanced and layered, not all sad, or at the very least, not all sad at the exact same time. Families are allowed to be joyful as they relish the opportunity to parent their child and eliminate their discomfort, while simultaneously being devastated by the loss and their own pain. So as we prepare the family, we want to offer anticipatory guidance about what to expect from their baby during the redirection. I walk families through the process from start to finish and offer really detailed and concrete descriptions for what to expect. This includes reviewing what normal body changes they can expect to see during the dying process. I address what they will experience in terms of their senses. So what will they see? Baby will be increasingly pale or gray, and then skin color can become dark after death. They also might see inconsistent chest rise as breathing occurs intermittently. What they may hear, gurgles or gasping. We explain that we'll medicate these to ensure comfort, but that the sounds at the end of death are often reflexes of a dying brainstem and not purposeful or conscious. We also explain what they may feel. So cold skin that starts in their extremities and becomes more diffuse. They also may notice a change in tone from one that is floppy to increasingly rigid. It's important to discuss how long we expect their baby to live. We, of course, can't be exact, but generally sharing whether we think it will be immediate or not can be really helpful in setting expectations. We also discuss how the de-escalation of care can occur. This includes whether we remove all respiratory support at once or change from mechanical ventilation to nasal cannula in hopes that the family would be able to see more of their baby's face and hold them with greater ease. They should know that this will not meaningfully extend the baby's life, but may offer additional minutes of time to bond. When extubating a baby, we can also offer removing the tube in the baby's arms or extubating the baby at in his or her bed and then transferring the baby to the family. This is really a personal preference to explore. We want to create an environment for the family that feels calm and controlled. We suggest turning the monitors off, as parents often get distracted and focus on the numbers instead of enjoying time holding their baby. We also want to offer privacy to these families, but also make sure that they know we're present for anything they need, including having someone be physically nearby in case of concerns or questions. We want the family to be comfortable and ensure that all staff know that they don't unintentionally disrupt the environment with loud conversations. So we really try to get everyone on the same page. When preparing the body to be extubated, we pre-medicate to ensure comfort and have additional doses readily available. We also suction the tube, mouth, and nares to minimize secretions post-extubation. We always maintain one point of access for the administration of medications. Obviously, something more stable like a PIC is preferable. We can also keep baseline drips running if that's deemed appropriate, but a PIV is, of course, acceptable. If you lose access at any time, intranasal fentanyl or midazolam or PO morphine can also be used. This all should be done out of the parent's sight unless they express that they would like to watch. And from our experience, the vast majority of parents do not like to be a part of this particular process. So as we're continuing to prepare the body, we remove from least to most invasive. So we start with removing leads and pulse ox. We can clamp and cut chest tubes if we're unable to remove them. If the baby's on ECMO, the cannula can be clamped and cut or just draped to cover. We remove NG and OG tubes and all lines with the exception of one access point like we just discussed. And then finally, we remove the respiratory support. It's important to consider what religious or cultural traditions the family values, as in some faiths, nothing should be removed from the body and is instead sent to the morgue as is. Other cultures believe that the baby should not be held after death, which can influence when we call time of death. We are in no rush to pronounce, and we communicate that to the family. We encourage them to take as much time as they would like to hold and bond and make memories. We always ask if they would like us to listen for a heartbeat, and we're happy to come back later if that is not a time that they feel comfortable or they would like to delay that.
So as your patient is near the end of life, ensuring that you've reached a state of comfort is crucially important. Addressing pain is one key component of ensuring your comfort is achieved. So how can we best assess pain in the neonate? And to be honest, there really isn't a perfect tool out there. This is a systematic review where they assessed 13 neonatal pain scales, and none of the scales evaluated in the study were found to excel in all areas. The research team identified 8 different categories that would ideally be incorporated into a tool. First being behavioral expressions of pain, such as facial expressions and body movements. There would also be a incorporation of physiological manifestations, such as increases in heart rate or changes in blood pressure. An ideal tool would also have contextual contributors added into it, such as the baby's corrected gestational age. And then it would also help determine the difference between chronic pain and acute pain, and also help distinguish between pain or stress. Ideally, it would also have some provider and parental input. And then really, as any tool that we use in the NICU or in clinical practice, it should have high inter-rater reliability and easy clinical application. And of the 13 scales that were studied, none comprehensively addressed all these areas in terms of neonatal pain. This review also captures how nurses are not always certain, based on the physical signs and on the clinical situation, if their patient was experiencing pain or any other symptoms. The review cited a lack of education, resources, and consistency in approach to the end-of-life care that contributed to overall provider discomfort. It's not enough to just have the tool, but you need to train nurses and staff to be comfortable using the tool. Nurses need to be comfortable using the tool, and providers should be comfortable with incorporating the nursing assessment into their plans. If a nurse is taking the time to utilize the tool and give you a score, but they see time and time again providers are kind of disregarding that assessment, it's going to be discouraging to the nurse to continue to utilize it. Of the tools that are available for neonatal pain, the evidence doesn't really allow us to make a strong recommendation for using one over another, but it is recommended that your unit uses at least some kind of tool so that everyone's assessing pain in a unified way. And to ensure that everyone's using the tool appropriately, providers really must be trained on how to perform it and how to interpret it. So our team utilizes the NIPS, the Neonatal Infant Pain Scale. And the reason we chose this scale over the others that are available is there's really no monitors or vital signs that are needed. The scale measures 6 behavioral parameters and can be performed just by assessing the baby in the parent's arms. It allows the provider to ensure they are addressing pain without interrupting the bonding with parents that we hope to promote at the end of life. When it has been studied, the scale performs well with assessing acute pain, but is not as successful in assessing chronic pain. So, as I said earlier, addressing pain is a crucial component to achieving a state of comfort in the dying process. When it comes to parental perception of pain, it again is important to think about the anticipatory guidance you give to families about what to expect, so they don't think that the expected changes we see at the end of life are actually signs that their child is in pain or distress. Schultz and colleagues surveyed bereaved parents and found that respiratory distress was perceived as both the worst symptom in severity and also the most difficult symptom for parents to watch their child experience at the end of life. Cortezzo and her team explored differences in perception of pain between providers and parents and found a significant difference between them. Whereas most providers felt pain symptoms were well controlled at the end of life, just over half of parents felt that pain was controlled. If you take a step back and think about that for a moment, that almost half the families in this study felt like their child was in pain at the end of life. Being present and seeing your child pass is an incredibly challenging in the best of circumstances. But thinking your child passed in pain can be incredibly traumatic for our parents. It is crucial that we as providers are present and able to help talk with families to mitigate any concern of pain so that families can be reassured that their child is not suffering. Brynn and colleagues demonstrated the importance of provider presence in the NICU, and that stated that parents cited clear communication with anticipatory guidance as being most helpful in preparing for the death of a child. So Our program, in which we have established relationships with our families, allows us to know how to best communicate with our parents to ensure they are understanding what is happening with their child. This is a study out of our institution from families who were followed by our Comfort Care team. It's a mixed method study that includes a questionnaire with both quantitative and quantitative response options as well as open-ended questions. 42 parents of patients followed by the Comfort Care team responded to the questionnaire, and 38 out of those 42 respondents stated that they felt like their infant was always in a state of comfort without distress or pain during their entire course of treatment. The success of the program in ensuring parents' perceive that their infant is comfortable and free of pain is in part due to our team's communication with the family to ensure they understand what is going to happen during redirection and what is actively happening during the end-of-life process. Qualitative analysis identified themes of caring, with respondents citing that their grieving process was aided by the fact that they felt like their child was cared for, loved, and was comfortable at the end of their life.
So comfort, from the Latin roots cum, meaning with or together, and fortis, meaning strong, suggests that the care offered is one based on accompaniment and strength. Comfort care is at its core relational, as the team walks with families through some of the most challenging moments of their lives, offering guidance, support, and strength. This relationship depends on connections between parents and their baby, as well as parents and the clinical team. Our program, as the previous study showed, is committed to the alleviation of suffering of any kind for both babies and the people who love them. And true suffering or discomfort must address the most basic psychosocial and physiologic needs of our patients. This table presents the core physiologic and psychosocial needs of neonates and offers non-pharmacologic methods to help achieve a state of comfort at the end of life. These methods can be used either in comfort care due to a fetal life-limiting condition or through redirection in the NICU. I know everyone's committed to meeting each infant's basic needs, and those needs are no different when they're at the end of life. So the first is bonding, which can be done with skin to skin or by encouraging parents to parent, like we've discussed earlier. We also want to make sure that body temperature is maintained. This can be done by skin to skin, or we have also used heat lamps or layered swaddles to make sure that they're warm, which we would obviously not do in other neonates. We also want to assure that the baby's not hungry or thirsty, and this can be done with bottle feeding, sometimes requiring special nipples and support from our speech language colleagues. Baby can also be put to breast, or in certain circumstances can even use an NG, OG, or G tube, which can benefit the sort of larger palliative care plan. If an infant is not taking anything by mouth or is too weak to suck and swallow, we can offer non-nutritive strategies like mouth care with colostrum or oral sucrose. And then finally, of course, the need to alleviate discomfort or pain. Non-pharmacologic methods to address discomfort include repositioning, gentle upper airway suctioning, and regular assessment of the need for pharmacologic treatment.
So when non-pharmacological management isn't enough, it's important to consider pharmacological therapy. We are going to do just a brief overview because, as Melissa has already kind of hinted at, next month is an entire webinar devoted to this. A question we often get from families is, will this cause my baby to die? Our role as the provider is to help dispel this fear. We want parents to be completely comfortable with the decisions that are made leading up to their child's death, and ensuring that they understand these medications will not hasten death is key to that occurring. 2 points are important to consider when discussing this with families. The first is there's actually been studies that have shown that administering both opioid and sedatives in appropriate doses to treat end-of-life symptoms does not hasten death and improves the perception of comfort during the dying process. I often reassure families that just like every other medication given in the NICU, these medications are dosed on weight to ensure that the infant is receiving the appropriate amount. The last point is that even if these medications were to have the side effect of respiratory depression and death, there's this accepted ethical notion of the principle of the double effect, which states that the action is justifiable if the nature of the act is good, meaning the good effects, in this case, achieving comfort, are intended as opposed to the possible bad effects of respiratory compromise, and that the good effects outweigh the bad given the circumstances. With this in mind, alleviating symptoms of pain and dyspnea at the end of life are considered standard of care. So this is a nice framework to thinking about end-of-life symptom management that I adapted from Dr. Corteza, a neonatologist and palliative care physician who's going to be speaking next month. These are the overarching symptoms that should be attended to at the end of life. This framework first has you address symptoms using non-pharmacological means before moving to medications. Overwhelming secretions and dyspnea are both symptoms that can cause a lot of distress, both for our patients and for their parents who witness them. For secretions, optimizing positioning so that the patient's upright as possible, as well as suctioning and fluid restriction when able, are ways to address secretions without turning to medication. If they continue to cause discomfort and distress, utilizing atropine or glycopyrrolate can be useful. Though I will say in our practice, we've rarely had to utilize them, as our nursing is very good at controlling secretions with positioning and suctioning alone. Dyspnea, as discussed earlier, is one of the most distressing symptoms for parents to witness. Ensuring the room is cool and sometimes even placing a cold cloth on the chest can help with this. Keeping the head of the bed elevated, as well as doing skin to skin, can also help. If these interventions aren't enough, using opioids to help with dyspnea is the next step. In our practice, when we're treating dyspnea and we do not have access, we'll use intranasal fentanyl and oral morphine. The fentanyl is as it's fast acting, and the morphine to help provide relief for a longer duration. For agitation and irritability, non-pharmacological management really can work wonders. Once you rule out pain as a cause of the agitation, attempting skin to skin, swaddling, or music therapy can all help soothe the child and can often work without additional intervention. If none of these work, and you don't have access, then a trial of a benzo, such as an intranasal midazolam or PO lorazepam, is warranted. If this doesn't provide relief, then revisit to see if you've missed the underlying cause, such as secretion, pain, or dyspnea being the root of the agitation. If you are able to get relief with intranasal midazolam, but it's short-lived, convert to using a longer-acting benzo like lorazepam. If you have access and agitation continues to be a struggle, then you can utilize a drip such as dexmedetomidine, which is useful as it will often provide relief of agitation without causing the infant to completely lose the ability to interact with their parents. For pain, again, it's important to address if you're missing a reversible cause. Perhaps there's a pressure ulcer that would benefit from repositioning or improved dressing, or skin irritation that would benefit from a topical cream. If you've addressed the possible reversible causes, then you should assess the pain level. If it's mild, you can certainly start with acetaminophen, but if the pain is more severe, then utilizing an opioid is appropriate. What opioid you use depends on the kind of access you have, as well as considering what opioids that patient has already been exposed to already. If you have a patient who has been on a fentanyl drip for some time, they may have developed a tolerance, and rotating to a different opioid might be appropriate. The older your patient is and the more drips that they have been on in terms of sedation and pain can make redirection and managing end-of-life symptoms a bit more challenging. In these scenarios, it's really great to utilize your local palliative care team. And if you don't have a palliative care team, utilizing a PharmD to help ensure that you're effectively thinking about how to best provide relief to our patients at the end of life. So given there's a lot to consider in the lead up to and the actual process of redirection of care, our team has created guidelines for our institution. We created the guidelines so our team members feel supported should they have to manage a redirection or a perinatal palliative care case without our team support overnight or on the weekend. Besides having the guideline in place, we also hold regular training sessions with our fellows and in-service the nurses on the labor and delivery floors, the postpartum floors, as well as the NICU. Particularly for our perinatal palliative care cases, who never enter the NICU, the message we try to get across when we are reviewing these guidelines is that the most important thing we can do for families is attend to them and show them that we care for their child, even though their life may be short. So though we have institution-specific guidelines, it's definitely not the standard. This is a study that evaluated the end-of-life comfort care practice throughout the country via an electronic survey that was distributed through members of the AAP section on neonatal perinatal medicine. There were over 300 responses from mostly level 4 and level 3 NICUs, and of the respondents, almost half reported that their institution did not have any comfort care guideline, and of those that did have a guideline, 20% did not include pain management in that guideline. 92% of those who responded to the survey indicated a desire for more training, education, and guidance around end-of-life care in the NICU.
So after we transition the death of an infant, it's important to continue to support both the family and the clinical team. So for the team, like Dr. Brady spoke about earlier, a debrief should be conducted to talk about what went well and what could be improved. It's also important to just offer a space for team members to process what happened, any emotions that may have come up for them, and then to make sure that they're aware of the resources that are available to support them. At the time of the infant's death, many moms are still lactating or are anticipating their milk coming in imminently. Some moms see lactation as a painful reminder of their loss, while others see it as a gift and an opportunity to honor their child. In our hospital, we counsel families about the range of lactation choices available to them, which include donation, where moms can choose to pump and donate their breast milk to local milk banks. Non-pharmacologic suppression is led by lactation consultants who serve an important role in educating moms about safe and effective ways to suppress lactation. Our OB colleagues can offer guidance on a pharmacologic method of preventing lactation, which includes the administration of the medication cabergoline that should occur within the first 24 hours postpartum. We use a multidisciplinary team to help surround each family with layers of support during their bereavement process. Social work will meet with the family to discuss funeral arrangements and access to grants for burial expenses. We have a child life specialist who specializes in comfort care patients and partners with our team to support families through memory making, including hand and footprint molds like you see in the top photo. Some of our families are unsure about bringing home physical memories of their child, worrying that it will only worsen their own sadness or traumatize their other children. We often share that based on the experience of families in our program, most are not upset by what they did to remember their baby, and instead often regret not having done more. Because of this, we ask permission to take a set of footprints and at least one photo, which we will hold on to in case they change their mind and in the future want to see them. When there are visible anomalies that can be upsetting for parents to see, we ask if they would like to see them first. And if not, we'll take a picture to keep in our records so that, again, in the future, if they would like to see it, they can do that. Sometimes seeing the anomaly is helpful as it reassures the family that the diagnosis is true and the information they were told prenatally was correct. Other times, depending on the severity, some parents share that seeing the anomaly actually taints the memory of their child and the peaceful experience we were able to foster. But no matter what keepsakes or photos are taken, the goal is to reinforce that their child is worth remembering, reminding families that their baby is the baby that they love is more than just the diagnosis that led to their death. As families continue to grieve, chaplains are available in our hospital for counseling. Our program also offers longer-term emotional support, including a monthly support group, like Dr. Brady mentioned earlier. We also have a psychologist on staff that's available for individual sessions. And then for those needing consistent long-term support, we'll help connect them to community resources.
So multiple qualitative studies with bereaved parents have shown that parents appreciate staff members showing emotion. Providers who showed emotion made parents feel seen and supported. Furthermore, parents felt offended by providers who were seemed cold or unemotional. I think some providers are afraid to show emotion for fear that parents or other staff might not appreciate it. However, showing empathy and some emotion is key to continuing to foster your relationship with the grieving parents. That said, you should never show so much emotion that the focus becomes on you. I have seen parents consoling members of the healthcare staff, and if you find yourself in a scenario where it's becoming too much, it's better to step aside and collect yourself rather than become the center of the grieving. During the grieving process, parents appreciate being acknowledged as the parent. For our parents, the classic parenting role has been stolen from them, and by acknowledging how great a parent they were to their child, by giving examples such as they never left the bedside, they were the best at being able to provide calm to their child, or pointing out what a great advocate they were throughout their hospitalization, are all ways that we can help validate their role as their child's parent. Another area we are often asked about is it okay to reach out to the family weeks or even months after the child's death? We encourage this to happen. Evidence has shown that families appreciate hearing from providers who took care of their child. If you think about it, for many of our families, the healthcare team had the chance to get to know their child, at times better than their immediate family members. It affirms to the family that their child had an impact and is not forgotten. So with our families, we send notes every year on the child's birthday as a note to remind them that we are here for them and their family. It invites families to reconnect with us and join our support groups if they haven't already done so. But more importantly, again, it signals to the family that their child had a lasting impact, not just on them, but for those who cared for them. And this is just a template of what we send to most of our families. It says, as his birthday approaches, we want you to know that we are holding you in our hearts and are remembering your beautiful baby with you. Though his time here was brief, he touched the lives of those around him. We remember him, your love, and the strength and tenderness you showed during such a profoundly difficult time. Please know that he is not forgotten. Today, we are honoring his memory and thinking of your family with warmth and compassion, with deepest sympathy and continued care.
So we recognize that this is a lot of information and only a really small part of what our program does and the larger perinatal palliative care. So we invite you to our annual 3-day training session that happens in person at Columbia. It'll be held in early November, the 5th through the 7th. And it brings scholars and clinicians across disciplines together to talk about things like the actual palliative care consult, obstetric counseling, the development of a perinatal palliative care program, continuity of care, spiritual distress, nursing competencies, ethics, the management of trisomy 13 and 18 specifically. And then we delve into difficult conversations in the NICU through breakout sessions. So you can scan the QR code to be brought to our website where we have registration information and additional resources available. For any questions about the training, please use the email at the bottom of the slide, and we hope you'll join us.
Thank you so much for your attention. We'll be happy to take any questions this time.
Thank you so much for that wonderful talk. I just want to remind all the participants to please use the Q&A tab below to submit your questions. And if it's okay, I'll start with some questions that we have received already. Could you please speak to bereavement support and funding?
Yeah, so we offer obviously the support group monthly, and then you have in-house staff members like psychologists and psychiatrists who we can reach out to. I think obviously it's a really challenging community resource. There's limited options, especially for patients that are on Medicaid. But there are wonderful organizations Postpartum Support International is a really good resource and has listings of local organizations across the country that offer support for families postpartum. This is for people that have lost infants, but also are just struggling with postpartum depression or anxiety. So I think that's a good place to start.
Thank you so much. Another asked, do you have any strategies to encourage more quiet parents to share their thoughts?
Yeah, I think that's always a challenge. And I think there's also times when one parent is doing all the talking and the other parent kind of just stays quiet. And I think for us, we use silence a lot in our conversations with families and really just invite them to speak and just give them space. And I think for a lot of our families, we have the benefit to get to know them very well over the course of our prenatal time with them, and then postnatally. So we get to know how the dynamic between the parents is. So that's helpful as well. But really being comfortable with silence and giving them space to process is, I think, probably the best.
Yeah, I think the other thing is that, especially at, academic centers, parents are often faced by a large group of people at one time. So I think trying to pull people to the side, to sit down beside them, physically sort of show that you're interested in having a longer conversation with them rather than just a drive-by with a group of trainees. So you're communicating that you care and you want to listen and you want to talk, and then asking them really specific questions that have nothing to do with the medical side of things. So tell me about his siblings. What kinds of things do you like to do at home? Like, I think just sort of probing their life at large can then lead you to a better sense of what their values are. And then again, building that trust to have more conversations about their medical care.
Yeah, and I think really just acknowledging that it is a lot. This is a lot to take in, a lot to process when you have a group of 10 doctors around you giving you information, and just acknowledging that and then sitting in that space with them to help navigate, like allying with them and sitting in that space to help them navigate it is also key.
Absolutely. Relationship building is so important. Another question asks, how can we support healthcare workers or other members of the medical team through the process of redirection of care and caring for the families?
Yeah, I think it's really important because we want the work that we all do is incredibly challenging and can be draining. And I think it's really important to make sure we're all taking care of each other. And I think realizing that you might have done lots of redirections of care, but realizing that not everyone has had the same experience is really important. So making sure you really doing that time to pre-brief to just discuss with your team what's going to happen, what do you expect to happen, how we're going to alleviate symptoms of pain, or and then also pulling them into the decisions that were and conversations that were had with the family leading up to the decision to redirect. Because, like I said, most of the team members are not going to be involved in those complex conversations that you had. So you are feeling confident with the decision that the family made and comfortable with that decision. That's because you were participated in all the decisions leading up to all the conversations leading up to the decision, whereas most of your team is not going to be involved in those conversations. So really bringing them up to speed so they understand where the family is. So there's really no moral distress around the actual redirection process, I think is really important for making everyone feel comfortable with it, and also making everyone on the team feel like it was successful redirection.
And I think one of the things that I try to do is circle back with the bedside nurse after the redirection. So seeing them several days later, next time they're on shift, and just trying to check in that was really hard. How did you feel that night? Like, tell me more about how you're feeling. Like, I think just it's the same thing our families need, that consistency, that accompaniment. So I think we try to do that for our clinical team as well. And it's not the day of extubation, it's a larger process and a structure that's there to support them through this.
Someone asks about the logistics or coordination of redirections occurring at home or how to create a home-like environment.
I think privacy is key to this. We have a room that has comfortable chairs and it has big windows and flameless candles and things like that that does try to mimic a room. I think in a planned, controlled sort of redirection, you have the ability to think through what things are important to them. Are there rosaries that they want to bring in? Is there a particular picture? So I think going through and asking them for details about their life so that it can reflect their family more. But I know a lot of us are limited either by space or time. So I think continuing to provide presence while also giving them a space to just sort of cry or to be silent. Sometimes that space is more important than any sort of, rosary or picture that they could have.
I think also, like we would if there was a other procedure happening on the unit, like a surgical procedure where you put like curtains, like blocking so people know what's going on, having appropriate signage around so that everyone who's not intimately involved in the redirection is aware is another way to address that, since if you're not able to move away from the bedside. And as we said in the talk, when you're talking with the family, asking them and providing suggestions on what they may want is important, because we had a family that all they wanted to do was bring their daughter outside, but the baby was on, before redirection, was intubated on nitric and on a pressor. So mom didn't even think that was remotely possible. But we asked and we asked what was she was hoping for her daughter to have before passing, and she brought that up, and we were able to do that for her. And she was able to meet her entire extended family in the garden outside our hospital. So I think definitely being used, leaning on your own experience and helping families walk through this, because this hopefully is going to be the one and only time that they have to participate in a redirection of care for their child. So, giving suggestions and helping them kind of process what would be best for them is important.
Thank you to everyone submitting questions, and I'll try my best to get everything in. Another person asked, how do you approach the subject of autopsy or organ donation in these discussions? And kind of related, there was another question saying, I've heard that lines should not be removed before autopsy. Can you confirm whether there are situations where more than a single access line needs to be left in?
Yeah, so if the family, so before doing the redirection and going to the bedside to remove things, you should find out if the family is interested in autopsy, because that will affect how you do the redirection. And you wouldn't, at least in our institution, we wouldn't remove lines or chest tubes in that scenario, because they would need that for the autopsy. But that is something that if you have the time to do it, but this is like a planned redirection, having that conversation about what an autopsy might help them in terms of find out for future planning, or in lines with like finding out about genetic testing, is important piece of information to have, so that you can have that in your planning process for, like, leading up to the actual redirection.
Perfect. Thank you. And then how can we How do you help navigate disagreements between parents and the medical team when redirection is medically indicated but not accepted? It's a tough one.
I think the term medically indicated is an interesting one in this setting because I think it's fundamentally about values. And I think the team and, the hospital can have opinions about an ethical care plan, and the parents can have a different one. And I think it's important to assess our own bias in these moments when it makes us uncomfortable, it makes us really sad, and we can project our own sort of opinions and what we would do in this situation onto this family. So I think recognizing our bias in these conversations is an important place to start. And then I think the other thing is we're quick to judge the family for whatever decision they're making. We hear a lot of times, oh, they just don't get it, which is one of the phrases I hate most in the world. Because I think if we ask a few more questions about why they have that opinion, or a few more questions about what led them to this decision, I think we can find more common ground, or at least places that we can provide them information that might shift their thinking. So I would encourage people to ask a few more questions, and sort of remove their own bias from that situation.
Thank you so much. Do you have any recommendations on how to collaborate across disciplines to achieve a cohesive palliative care pathway?
I think for us, what's worked is, relationship building and finding people that are genuinely interested in the work. So as we said, we have a child life specialist who really has become passionate about the work that we do, and really championing her and trying to get her involved in our cases, both prenatally. She talks to some of our families about how to work with siblings, and then postnatally as well, like getting her involved in doing the memory making. So I think, like anything else in the hospital, it's really just finding those people that are passionate about it, and then trying to support them and to help them do their job in like the best way possible to help them stay excited and engaged with your team.
I think we also try to, when people feel like a part of the team, they feel more willing to sort of cooperate and communicate. And so we have some of our MFM colleagues will attend our regular weekly rounds. Like we sort of try to integrate some of the specialties that we see more frequently into our regular programming, our regular sort of conversation, so that we really keep those lines of communication open and they can understand the way that we do things and the way that our relationships are like with our patients.
Thank you so much. Another person asked, you talked about teaming up with multiple disciplines. Do you have any recommendations for doing that with different hospitals? For example, a mother is admitted to L&D in one hospital and the NICU is located in a separate hospital. How do you make it more patient focused and work around this location separation?
Yeah, that is incredibly challenging, and that's one major benefit here is that our delivery hospital is actually within our children's hospital. So our moms are 2 floors, who are still admitted, are 2 floors below our NICU. So it makes it we have a lot more flexibility in terms of how we are able to manage these cases. Like for our perinatal palliative care cases, who are choosing comfort care, they stay with their mom on the postpartum floor. They're actually on the antepartum floor, so they're away from like the family's away from healthy crying babies, but they're all within the same hospital. So I recognize that is definitely a big challenge. I don't know if you.
Yeah, I think the only other like two sort of more concrete example like suggestions is using technology. So using things like FaceTime, using bedside iPads, things like that. You can record voices, like record the mom speaking to the baby and have that at the bedside. Another thing that we do is we have these little like fabric hearts that we will swaddle the baby with. And so it will get the baby scent, and then we will have the mom also carry another piece of fabric usually in her bra. And then we'll switch them so that the mom will carry the scent of the baby and the baby will carry the scent of the mom. And obviously, any parent can do that, but it's not the same as being able to be there. But I think bringing voices, bringing smells, like trying as much as possible to find ways to connect when they're separate. But we don't envy that position that you're in.
Thank you so much. I do see we're over time, so just for time's sake for everyone, thank you to everyone who submitted all these questions. Thank you both so much. Once again, Dr. Sinead Brady, Brynn McNamee-Tweed, thank you so much for the lecture today. And again, here are all the QR links, which will be emailed after the session is done. Thank you to everyone who showed up. Have a great day.
Thank you so much. Thanks for the invite. Have a nice day.